Theo Aguilar Gagiola will do the introduction. He's a professor of medicine at the UC Davis School of Medicine and the founding director of the Center for Reducing Health Disparities. He's kind of a visionary and driving force in understanding the mental health delivery problems that affect underserved communities. He's been a really important figure at UC Davis as well. And it's a real pleasure to have you here, Sergio, to do our introduction. Thank you.
Thank you so much, Dr. Kravitz. I know him as Rich. It is a genuine pleasure to be here, and especially for this talk that we are going to hear. And just very briefly, I had a chance to speak with our speaker, Dr. LeBron, a few minutes ago, and we commented that there are some parallels on the research that she's doing with the work that we are doing also at our Center for Reducing Health Disparities. Briefly, one thing that we had been working on transforming the health and mental health service delivery, especially for underserved populations, including Latinos, at the local level, and it's work that we are doing currently. And in the process of doing that work, we have done a series of focus groups, key informant interviews, and community forums. And one of the things that has emerged from that particular work is the fear and uncertainty that immigrant populations, certainly Latinos, have on the political climate that we are currently experiencing. And also the confusion that exists in terms of the policies at the national, state, and even local levels. And so I think that Dr. LeBron's talk, and in a minute I'll introduce you, is very timely, very relevant, very important, and I'm really pleased, delighted that Dr. Kravitz invited me to introduce the speaker. So you all have the flyer for Dr. LeBron, so I won't go beyond what, I'll just complement a little bit what the flyer says. And Dr. LeBron is an assistant professor of Chicano Latino Studies at the School of Social Sciences, and also assistant professor of public health at the University of California at Irvine. She had a very solid, very impressed with her training, got a bachelor's, a master's at Harvard, and also a PhD at the University of Michigan. And her work and the publication track record is also very, very solid. And specifically in the topic of the talk that she's going to give us. Her research considers the health equity implications of immigrant policies and sentiments towards immigrants, neighborhood social and economic context, and government issue ID policies and practices. And something that particularly called my attention, and that's where I think that we have these parallels, is that Dr. LeBron's scholarship also evaluates the health equity implications of community-driven strategies to mitigate these processes. So it is not only to try to understand these processes, but coming up with solutions, with specific interventions on how to mitigate, the health inequities that these populations, and particularly Latinos, experience. So it gives me great pleasure to introduce Dr. Alana LeBron.
Good afternoon, everyone. Thank you very much to the UC Center Sacramento for the opportunity to join this discussion today. The title of my talk is ID Policy and Immigration Policy as Health Equity Policy. And as an overview of my presentation today, I'm going to begin by offering a few frameworks that really underlie the work that I'll be sharing today. In focusing on health and healthcare, I'll talk a bit about how restrictive ID policies and immigrant policies shape the health and well-being of Latina, Latino, and Latinx communities. I do want to note that there are also implications of these contexts for other racial minority communities, but the majority of my work focuses on Latinos, and so that's the work that I will share today. So I'll focus specifically on findings based on the early 21st century, but I do want to acknowledge that these processes are ongoing. That is, they didn't just start in 2016 or in the early 2000s, and these processes are also dynamic. So following a presentation of some of the literature documenting the health impacts of these policies, I will close by pointing to important and promising opportunities for policy and practice. So to start, I want to note that racial and ethnic meanings are constructed and reconstructed socially as a part of the process of creating and reinforcing social inequities. A first step in social stratification or othering processes involve othering, which means creating a group or a difference between social groups and establishing an other group. So establishing a minority or a marginalized group vis-a-vis a dominant or superior group. The next step in this process involves defining the boundaries between those who are in the other group and those who are not in this group. And once those boundaries are established, these processes involve devaluing whoever is in this other group. And institutions and social agents use these symbols of differential value to justify inequitable access to resources for those who are constructed as being members of these inferior other groups. So these racialization and social stratification processes are relational, and they affect all groups, including those who are constructed as this other group and those who are outside of that group. Race is just one example of how these othering and social stratification processes operate. Importantly, other social statuses and identities such as gender, socioeconomic position, and immigrant generation are also involved in these processes. And these are dynamic processes that can also be contested and negotiated, and they vary across social, political, and geographical contexts, as well as the historical moment. Some of you may have seen this image previously, and for me, it's an important reminder of the differences between equality and equity. As you can see on your left, we are reminded that equality refers to everyone benefiting from the same thing. However, this only works if people are starting from the same places or if they're in the same circumstances. On the other hand, equity is about fairness. Equity gives people access to the same opportunities, though this is through different supports to ensure equal opportunity. So first, we must ensure equity before we can enjoy equality. So in thinking about the other side of equity, Margaret Whitehead of the World Health Organization explains that our theory of the issue, that is inequities rather than inequalities, really shapes our theory of change or intervention. She explains, the term inequity has a moral and an ethical dimension. It refers to differences which are unnecessary and avoidable, but in addition are also considered unfair and unjust. And so in order to describe a certain situation as inequitable, the cause has to be examined and judged to be unfair in the context of what is going on in the rest of society. So these two frameworks of othering processes and social stratification processes and inequities lay an important foundation for the review of immigrant and ID policies that I'll now discuss. So U.S. immigrant policies, or policies that regulate the lives of immigrants in the United States, have long been racialized. In the case of Latinos, in discourse and in practice, Latinos are often characterized as foreigners, whose citizenship status is suspect, if not assumed to be unauthorized. In the 21st century, according to the US Department of Homeland Security, the number of deportations from 2000 to 2015 exceeded the total number of deportations in the 20th century. This increase in deportations coincides with expansions of programs like the so-called Secure Communities program that extends the geographic reach of immigration enforcement across and within each state by coordinating federal and local or county law enforcement resources. In addition to bringing immigration authorities closer to day-to-day life, interior immigrant policing operations are salient to Latinos, as immigrants from Latin American countries represented 96% of deportations from the United States since 2010. And while technically these policies are focusing on undocumented immigrants, evidence suggests that for Latinos, the effects are felt for US-born and immigrant Latinos, and for immigrants who may have more protected immigration or legal statuses. So for example, after Arizona lawmakers passed a law mandating that local police inquire about the immigration status of people during routine traffic stops, so SB 1070, a 2010 survey of Latino voters in Arizona found that 72% said they believed that police primarily targeted Latinos in enforcing this policy. And a later 2011 survey found that a majority of Latinos believed their group was absorbing the brunt of these restrictive immigrant policies. So Latinos in Arizona thought SB 1070 was about them. And this really points to the reality that people are sensitive to state and federal immigration policy contexts. And for Latinos, deportation is not an abstraction. It is a reality that brings concern for relatives, friends, and coworkers, and students across Latino communities. In 2015, an estimated 61% of Latinos reported knowing someone who is undocumented, and 36% reported knowing someone who had been detained in immigration detention or who had been deported. And recent research has documented reduced healthcare utilization and use of public health services following state-level restrictive immigration policies. And these patterns can reflect really corroded trust in public institutions. These vigilant responses to the shifting context of restrictive immigrant policies is demonstrated in declines in healthcare utilization and use of safety net programs reported throughout the country since the change in presidential administration. So the consequences of these policies reverberate through communities through mechanisms including racial profiling and social networks. And the context affects not only undocumented immigrants, but it also spills over to affect naturalized citizens, non-citizen immigrants, and US-born Latinos. And individuals, families, and communities are making very careful assessments of this immigration environment. So these processes are more complex than simply immigration enforcement. And in my talk today, I'll shed a bit of light on the tight network of policies and institutions that are really making day-to-day life for immigrant communities more challenging. Restrictive ID policies are one example of some of those complexities. So restrictive ID policies render access to health-promoting resources really a privilege that's only available to people with a current government-issued ID issued by a US state. For example, the 2005 Real ID Act requires proof of authorized US presence in order for state-issued IDs or driver's licenses to be used for federal identification purposes. This policy particularly affects undocumented immigrants, and it also affects other communities who encounter barriers to proving their identities or their authorized US presence. So state responses to this federal policy have really tightened the criteria for obtaining IDs. And as this slide shows, in 2015, in response to this Real ID Act, 40 US states denied driver's licenses and state IDs to people who could not prove their authorized US presence. Importantly, this context really enhances inequities between individuals who have government-issued IDs and those who do not. So I worked for several years in Detroit with the Healthy Environments Partnership, which is a community-based participatory research partnership. And our qualitative research with Latina residents who lived in Detroit really illustrated that this policy context has implications for well-being of immigrants, of mixed status families, and of immigrant communities more broadly, as they certainly navigate the threat of deportation for oneself or loved ones. And our work also illustrated that this immigrant policy context affects a host of social and economic opportunities that are linked with health. So Detroit, Michigan has experienced a longstanding presence of immigration-related border enforcement agencies who are there because of their proximity to Canada. So in one community where a bit of our research focused, it was sort of dubbed as Mexican Town, reflecting the longstanding presence of Mexican residents and other Latinx subgroups in that particular neighborhood. And that neighborhood was very close to the bridge to Canada, where border enforcement would often travel. And like many other cities and towns, Detroit has also been affected by the increasing presence of immigration enforcement through the ramping up of interior immigration enforcement, and also through increased collaborations between federal immigration officials and local police in and around Detroit, the Motor City. So in our interviews with immigrant and US-born women of Mexican origin, we found that social agents leverage several racializing markers in the process of determining immigration status. That is, the condition of women or their loved one's own legal status and the deportability that is socially, politically, and juridically produced in this context. So the racializing markers that these social agents used included not having a current state-issued ID or driver's license, or having an expired ID or driver's license, speaking Spanish or having a Spanish accent, being born outside of the United States, having an ethnic name, and living in Southwest Detroit because of ways in which race-based residential segregation operates, and also physical features like a darker skin tone. So each of these symbols were linked with women's reports of heightened scrutiny of their immigration status. As Angela explained, the threat we live with every day, the first thing is the shade of your skin. Because if you look Mexican, that's when the police go after you. And then if you don't speak English, well, that's worse. Women also experienced a lot of questioning of their immigration status, and this was an experience that was also held by women who were born in the United States. The emphasis on immigration status also extended to their children, and this is a quote from Alice, who was describing an encounter with a caseworker as she tried to access WIC, right, so the Supplemental Nutrition Program for Women, Infants, and Children. She explained, "They assume that I am not from here, so they treat you like what makes you feel like you should not have WIC, like you are not a citizen or whatever. I had to explain to them that I am from here and that actually, technically, it's not for me, it's for the baby which was born here." So US-born women's entitlement to citizenship privileges were continually questioned, and they were often burdened with proving their citizenship while navigating and affirming their identity. A common response across women was that of hypervigilance towards these threats for oneself and for their loved ones. And the connections between multiple federal and state policies became clear as women talked about the day-to-day ways in which their state ID or driver's license surfaced in everyday life. For them, ID policies were immigrant policies. So Liliana explained here, why is it important to have a license? Because a lot of people don't want to drive because they are afraid that the police might stop them. And then they'll get asked for their license. If they don't have a license, they'll call immigration. If you have a license, there's no reason at all for them to call immigration. So several women described these systems as clipping their wings or making them feel like caged birds. And this analogy really speaks to their experiences of multiple systems of blocked opportunities by virtue of their social location and the symbols that are invoked in these processes. These references also signal the enduring health impacts of these immigrant policies, that there may be psychosocial and also physical impacts that accumulate and are injurious to the body over time. So in bringing all of this together, women's accounts really illustrated the interconnected and the dynamic nature of their experiences with these processes through immigrant policies. And it also really sheds light on the linkages to institutions that are charged with promoting the public's health. For example, immigration officials enacted their power and their surveillance of residents and immigration detention or deportation, often when they surveilled residents within and at the boundaries of their neighborhood that was known to be an ethnic enclave. These practices are embedded within a context of heightened immigration enforcement quotas, blocked pathways to citizenship, and the constitution-free zone in Michigan in which law enforcement agents have more liberties. And police exercise their authority over driver's licenses and contact with immigration officials. This form of surveillance often occurred when driving and conducting activities related to caregiving and employment responsibilities. These practices were linked with enhanced collaborations and information sharing between local and immigration enforcement officials under the Secure Communities program. And in Michigan, the Secretary of State's office issues and renews state IDs and driver's licenses. In 2008, the Secretary of State began denying licenses and IDs to undocumented immigrants. This is a state response to the 2005 Real ID Act that required that states ensure that folks can prove their authorized presence in order for these IDs to be used for federal identification. And so clerks within the Secretary of State's office exercise their discretion in assessing immigration status and in issuing state IDs and driver's licenses. Importantly, these IDs are needed to vote and to access a host of health-promoting resources for oneself and family, and I'll dig into that a little bit more deeply momentarily. Additionally, social welfare caseworkers exercise their authority in scrutinizing eligibility for nutritional and medical assistance for women and their children. And these practices are born out of past welfare policies that require proof of identity and citizenship in accessing Medicaid. Additionally, the 2010 Patient Protection and Affordable Care Act, also known as Obamacare, excluded certain immigrants from access to health insurance expansions, which really enhanced then the structural space between citizens and non-citizens. And then finally, employers exploited these vulnerabilities in their efforts to justify discriminatory treatment, such as wage theft and more difficult work conditions. Employers leveraged federal surveillance of their hiring practices as justification to exploit workers with more vulnerable citizenship statuses. So each of these is an example of an interaction that is happening at the interface of a legal institution. And some of these institutions are often housed within departments of public health or some healthcare institutions. Others are institutions that public health interfaces with on a regular basis. And the driver's license was really a central symbol that these institutional agents engaged in assessing women's access to resources. And the constant need to navigate within this interconnected space really creates a context that contributes to psychosocial stressors and has important social and economic implications that are tied to health. So government-issued IDs affect access to a broad range of resources that are linked with mental and physical well-being. And unequal access to IDs is a health equity concern. The Latino immigrant community in Flint, at the height of media attention to the water crisis, really reminds us of these realities. One woman explained, "I got close to see what they were giving out, and it was water. The first thing they asked me for was my license." So here she's explaining an encounter at a water distribution center, right, when bottled water was available to residents at the height of this situation in Flint. And so this really points out that restrictive ID policies are also compounded by exclusionary interpretations of those ID policies. So 21st century federal policies and bureaucratic institutions' interpretations of such policies have really increased the need for US government-issued photo ID to access a host of social, economic, and healthcare resources to promote health equity. As one example, the 2001 Patriot Act requires verification of customers' identities for financial transactions. And consequently, many financial institutions have implemented policies requiring a current government-issued ID issued within the United States. And other institutions have issued de jure or de facto government-issued ID requirements that also affect the social determinants of health. So health-promoting resources with ID requirements can include, for example, housing, such as applying for leases or even trying to see housing. Healthcare, including proving someone's health insurance status, proving your identity to a healthcare administrator, or accessing pharmaceutical resources, so getting regulated medication or picking up a prescription. It also affects financial resources, including getting a banking account or applying for a loan or cashing a check. It also reaches into political enfranchisement, so thinking about IDs that are needed to vote in some places. ID policies make it difficult to access identifying or governmental records, such as a birth certificate for oneself or for one's loved ones. They're also needed to access a host of goods and services. So if you think about purchasing an item with a debit card or a credit card, or purchasing something with a check. IDs are also needed to purchase age-restricted goods like alcohol, to access a range of community resources. So think about applying for a library card or getting nutritional assistance through a food bank. In those instances, IDs are often requested or required. And IDs are also needed for caregiving responsibilities. So to pick up a child at school, for an example, an ID may be requested. IDs are also needed to safely prove identity to law enforcement in order to prevent detention or interaction with other law enforcement agencies, such as immigration officials. And so because IDs are now gateways to health promoting resources, ID policy is health policy. So this work in Detroit really points to the local experiences of immigration policies and can be informative for understanding both national and subnational experiences in this protracted context. And I'm going to now transition to zoom out from Detroit to thinking about implications of these contexts for national patterns as well. So my colleagues at UC Riverside and Indiana University and I are developing a concept of cautious citizenship to really capture an emergent type of civic engagement in the United States that may be applicable to other countries as well. This theory of caution citizenship really centers the experiences of members of marginalized communities within governments that proclaim, at least in word, commitments to equal citizenship. A key feature of cautious citizenship, as we define it here, is that there is an awareness of citizenship gradients. So even those with formal citizenship may exercise cautious citizenship as a result of being sensitive to expanded citizenship surveillance practices. So citizenship surveillance can occur through a formal immigration enforcement apparatus or through scrutiny that is leveraged through exclusion and welfare state policy-based design, where identifying information is often required and where bureaucrats can engage in racial profiling. So for this work, we tested the hypothesis that immigrant politics can provoke aversive responses for Latinos through a population-based experimental study design. We embedded this experimental design within the 2015 Latino National Health and Immigration Survey. So in this design, we randomly assigned respondents to receive either a health insurance queue or an immigration issues queue, and we wanted to compare the effects of this very subtle exposure to see whether it deterred or promoted willingness to use key services independent of other factors. And the outcome variable that I'll share for the purposes of this presentation focused on the likelihood to make a healthcare appointment. So as an example of how this experimental design worked, participants were asked, when thinking about making an appointment to see a doctor or a nurse or going to a clinic for healthcare, with all of the attention to health insurance or all of the attention to immigration issues, are you more likely to use healthcare services, less likely, or has it not made a difference? And so we examined some mechanisms by which Latinos might engage in cautious citizenship, including whether respondents know someone who is undocumented, or if they know someone who has been deported. And we are also examining variation by perceptions of state policy context towards immigrants that offers another way of capturing the lived experience of immigrant politics in day-to-day life. So what did we find? So the following figures show the likelihood of making an appointment to see a healthcare provider by experimental arm. So people exposed to the health insurance queue are represented by the gray circle, and those receiving the immigration issues queue are represented by the black diamond. And as you can see here, in looking at just the total samples, Latinos were less likely, to make an appointment to see a healthcare provider when the immigration issues queue was mentioned to them, really signaling a 7 percentage point deterrence effect of exposure to that really subtle cue. So this suggests evidence for an aversion hypothesis, that Latinos are engaging in cautious citizenship when immigration politics are salient. And we see that this effect is magnified for Latinos who know someone who has been undocumented. So we see an average deterrence effect of about 8 percentage points for Latinos who know someone who's undocumented and who were exposed to that immigration issues queue relative to people exposed to the health insurance queue. And trends suggest a slight deterrence effect for people who do not know someone who is undocumented, but these differences didn't reach statistical significance. And the deterrence in propensity to see a healthcare provider is also augmented for people who know someone who has been deported, contributing to a 12 percentage point deterrence effect that was statistically significant. And there was no effect, as you can see, of the experiment on those who did not know someone who was deported. So what about state level differences? Perceptions of the state policy context towards immigrants has a similar effect as knowing someone who's been deported. So people who lived in states that they perceived to be unwelcoming towards immigrants exhibited a 12 percentage point deterrence effect when they were exposed to this immigration issues queue compared to those who were primed to think about health insurance related considerations. And there was no experimental effect for people who perceived the state policy context to be welcoming for them. So these processes and individual, family, and community responses to restrictive immigrant and ID policies have implications for public health institutions as well, so not only in healthcare-specific settings. Our recent scholarship involving a different national sample found that Latinos who live in locales where immigrant policing is most intense express lower levels of trust in the government as a source of health information. We did not see this pattern for other racial groups. So together, these findings really point to policy feedback, that the nation's deployment of immigrant policing and a host of other policies that are restrictive towards immigrant communities convey more widespread lessons to Latinos about the trustworthiness of public institutions. So what are the health implications? How does this get under our skin? Literature that links chronic activation of the stress response system to accelerated aging can teach us about the life course implications of this context for the health of Latinos. An accumulating body of evidence documents the health impacts of restrictive immigrant contexts, including enhanced cardiovascular risk. And this literature is pointing to pathways that include worrying about deportation and also experiences of institutional discrimination, in which institutions and institutional agents are restricting access to health-promoting resources. A recent study also documented adverse birth outcomes for immigrant and US-born Latinas following a large-scale immigration raid. And immigration raids can be conceptualized as acute shocks to communities, or particularly acute sites and experiences of oppression that can be harmful for health in the short term and later in the life course. Other work has linked poor mental health with living in a county with high levels of deportation. And yet other scholarship documents poorer self-rated health following a local immigration raid, and also links concerns about racial profiling from police with poorer self-rated health for US-born and immigrant Latinos. So in tying all of this together, these findings really suggest that immigrant policy is health policy, and that ID policy is also health policy. This work also shows how the federal laws and state responses to those laws have operated to enhance othering processes and inequities. And the qualitative work that I shared points to the profound discretion that bureaucrats and institutional actors, such as police and service providers, have in interpreting and applying the law. And Latinos have carefully assessed this dynamic and shifting context. So together, this work suggests that Latinos do not have to experience these politics intensely to have this context and these systems affect daily behaviors, decisions, and outcomes. That is, Latinos understand the negative intent behind contemporary immigrant politics, and this can provoke an adverse response. Additionally, risk or protective factors in relation to the tentacles of this restrictive immigration policy certainly varies by Latinos or within Latino subgroups, as some of that experimental design began to shed light on. So immigration politics are operating as a threat that really creates a crisis in governance and the provision of public health goods, including, for example, reporting a crime or seeing healthcare-related providers. And these findings shed light on the careful assessments that individuals, families, and communities are making about their likelihood of becoming further ensnared in the tentacles of our growing immigrant policing structure. And although the data that I shared with you today were collected prior to the presidential campaign and the subsequent election, the patterns are also instructive for several reasons. So first, so far as the current administration's rhetoric and commitment to implementing restrictive immigrant policies represents an escalation of the context that we studied, one implication of these findings is the widespread deterrence from using public services amongst Latinos that may sow seeds for future inequities in health and health care. These findings suggest that racializing public services may nudge Latinos to see providers of a host of resources as sources of political threat rather than heroes or advocates. And because of these contexts, people may have to make difficult decisions to access such services or risk deportation. And second, the implementation of restrictive immigrant policies can disrupt the ability of service-providing officials to do their job, at least in part because Latinos are a growing share of the clientele all over the country, and because these systemic avoidance of police and doctors that we're seeing unfold really introduces inefficiencies to a range of social and economic relations. Likewise, mandatory reporting by service providers can deter undocumented immigrants and friends of family members from seeking needed services if they're experiencing some type of context that may fall under the mandatory reporting conditions. So they may see accessing these services as a binary choice of accessing services and risking deportation, or not accessing services and preserving the opportunity to remain in the US for themselves or their kin networks. And a question that many communities, local governments, and healthcare providers and public health practitioners are asking is how to promote health and well-being of immigrant and racial minority communities in the context of heightened immigration enforcement and anti-immigrant and, by extension, anti-Latino sentiments and ideologies. So I'll speak just from my perch in public health. So in public health, our charge is really to focus on social factors that shape individual, family, and community health, and to intervene on the social and the physical context in which people live, learn, work, and play to promote health. And there is important evidence that we need to enhance access to resources such as safety net programs and healthcare in order to ameliorate the health consequences of living in an inequitable world. So what does that look like? We need to partner with communities who hold deep and intimate knowledge about these issues, as well as community strengths. So community members have important insights into appropriate solutions. And this can create opportunities for co-ownership of the assessment and the intervention process with communities that is important for enhancing the likelihood of effective and sustainable public health action. And a public health approach to building health equity involves addressing the contexts that create and reproduce social inequities that in turn can undermine health. The solutions to public health challenges of our time are found when we work with multiple actors. So coalition building models offer great promise. California has taken a positive step in this direction by enabling access to driver's licenses and state IDs for undocumented immigrants. But I'll acknowledge that these IDs also serve as racializing markers because of their distinguishing factors. So policymakers must be cognizant of this in reviewing how the state will respond to federal restrictive ID policies, as just one example. Additionally, California is taking an important step by disrupting collaborations between federal immigration enforcement officials and local law enforcement agencies. So this is great progress. And recently, we've seen a call to abolish ICE, right, to abolish immigration and customs enforcement. But I'll offer that we need to be vigilant. If we are successful in abolishing ICE, we need to ensure that we don't just dissolve one institution to have their responsibilities creep into or move into the responsibilities of other institutions. So think about local community police, for example. This work may also involve educating state and local policymakers about the health impacts of restrictive ID policies and the potentials of shifting from one institution to another. We also need to step up when jurisdictions are considering decisions that would undermine the public's health and well-being. I also want to acknowledge that while we're in a moment that seems very top-down, it's important to remember the value and the power and potential of community-driven solutions. So local communities have great power to develop these policies that reflect the values of inclusion and that strengthen community trust. We also need to look inward and reflect on ways in which our institutions produce and reproduce inequities. This may surface a need to really strengthen organizational capacity to identify processes that contribute to health inequities or to partner with communities in this work. And there are important examples of organizational level interventions, such as undoing racism interventions, that can support institutions in moving towards this goal. And we need to ensure that our institutions truly reflect the constituents or the communities that they're intended to serve. And finally, in closing, I recognize that we have much work to do, and I'll offer that we need to listen. We must listen, and there are promising models that we can look to pursue health equity in an inequitable world. Thank you.